So let's see, is everyone here? Is Harold here? Is Tim here? Is Al here? Is Penny here? Oh, I see Penny in my screen. I feel like we're on that show where I see Penny, I see. Are we missing anybody? Are we ready to launch? Is Harold here? Yeah, it says no, not yet. Hey, Marissa, how are you?
Here.
Oh, there you
Hi,
are.
Toni. There he is.
Hey, how are you? Look, Harold put on a work shirt and a work tie. Go ahead. Go ahead. You said the people won't talk about you, huh?
I've been running from back-to-back meetings, and so you just got the leftover clothes.
Okay. So now I got leftover clothes. I don't think you're supposed to tell me that part, right? So I mean, so I'm gonna go ahead and get this party started. For those of you who've not joined us on either the West Virginia stakeholder meeting or on a rural health service provider meeting call before, you will know, you won't know, but these are very informal. But we wanted to set up consistent opportunities for conversation, dialogue, as well as introduction. Sometimes we talk about heavy topics, and sometimes we talk about policy and other topics. But today we want to talk about something I think that it's it's like a convergence of things all at the same time. The Ending the Epidemic strategy is working well in some places. I think not so well in some other places. Sorry, Harold. And, in places like West Virginia, which, I believe should have been included, that weren't included, but we'll talk about that. We'll live for that fight another day. But the other challenge that we're seeing in some rural jurisdictions and some of those jurisdictions that didn't expand Medicaid is this new issue around ADAP and ADAP deficits. I think that Texas had like a $52 million deficit in front of them. And I think that they worked it out with the governor, but we're also having to use some COVID relief dollars. And we're seeing it in Tennessee. We saw something happening in Georgia. So I think we want to have a conversation today about what do we need to be looking for. I originally thought maybe we needed to do some sort of predictive modeling to say, well, if this, and this happens in your jurisdiction, what do you think we need to do next? So between myself, David, and Marcus and us, we came together and we said, okay, who are some of our smartest friends that we know? And who are some of the best and the brightest in this space? And so we reached out to Harold, we reached out to Tim, we reached out to Ali, we reached out to Alicia and Penny, right? So today, I want to have a conversation about kind of what do we need to do to protect ADAP in this environment? But first of all, what is ADAP? And I'm going to have probably have Tim talk a bit about what ADAP even is, because we might have some folks on the call who don't even know what we're talking about with ADAP, because our participants usually run a wide range. Some folks know, some folks don't know. So I've known Tim for 250 years, since he was a wee pup, wet behind the ears. I think that if I recall this correctly, they used to say, that Tim was a youngin', and now he is.
Be careful. Be careful where you go with this.
I did, and I actually changed what I was going to say twice because I was like, that's right, this is a mixed call, so I won't use those terms that I was about to use. But either way, he's always been one of the smartest people in the room. And one of the people that and people who know me know it's difficult to get me to shut up, but he's one of those people that can always make me shut up and listen. So Tim, what is ADAP?
Sure. Okay. So, when we think about ADAPs, ADAPs are the Age Drug Assistance Program, and ADAPs are funded primarily under our Part B, under the Ryan White HIV/AIDS program. So, really, what the Age Drug Assistance Program is charged to do is to really ensure that people living with HIV who meet all the eligibility criteria. So, it's really about serving our low income and our middle income individuals in the United States who are living with HIV. And really what ADAPs are charged with is ensuring that people have equitable access to treatment for HIV, as well as preventive and treatments for opportunistic infections, and of course other medications that are critical to people living with HIV. So why is that so significant? Well, one of the reasons why that is so significant is that when we think about HIV care, and you think about HIV care versus primary care versus virtually most other diseases in the United States, whereas you take a look at in terms of what our expenditures are in HIV, and that like 60% plus of HIV care expenditures are the medications that are used to treat it. So having a program that is really charged with ensuring that people living with HIV have access to critical HIV medications, critical medications to prevent and treat any of the AIDS-related infections or diseases, and a host of other different conditions that are really quite common in people living with HIV is absolutely critical. Now, what ADAPs are is they are effectively a payer of last resort. So they really are our safety nets. In fact, I would probably say that they are our safety nets below the safety net. They are really charged with ensuring that folks who absolutely need access to treatment and access to HIV care have that. So really, it is a it's just like the preference is to ensure that folks have access to comprehensive insurance. So for folks who making sure that they have access to to Medicare, Medicaid, commercial insurance, and where that access point does not exist, ADAPs are there. So ADAPs are in a very unique position. In fact, ADAPs are unlike any other program in the United States. That they really are. They complete. Or they more or less complete that patchwork that is absolutely critical to people living with HIV. So, I mean, there are a number of different sort of rules and regulations and, can'ts and cannots around, ADAPs, but that is essentially the way they work. Now, the thing about, ADAPs and the reason why ADAPs are such a, sensitive point is that, ADAPs, they operate with finite resources, with finite financial resources. And that is an absolutely critical thing to think about. And that thinks about just in terms of, what we're trying to achieve on a day-to-day basis, but even as we begin to think about ending the HIV epidemic, really sort of like the jumping off point for this conversation in terms of ADAPs at the intersection of ending the HIV epidemic is that, that they're really operating with finite resources. So when we think about ADAPs, ADAPs do not have the advantage of being able to charge premiums or to increase premiums or to charge deductibles or to charge cost sharing in this way, to make the program more sustainable. They don't have that luxury. They don't have the ability to apply complicated cost effectiveness analyses to their work. So they're saying, well, if we invest now, we're going to prevent hospitalizations or even deaths down the road. They can't use that. So really, they are operating within a very sort of finite structure. So this is what we're thinking about, that ADAPs are charged to do a lot, and we need them to do a lot with finite resources. So as we begin to think about this in the concept of the HIV epidemic, that is going to be a very important lens with which we approach ADAPs and in terms of what they are and what they're capable of.
Okay, so now Harold, I'm going to pivot back to you because you are Mr. Ending the Epidemic on behalf of this administration and others. So tell us, first of all, what is the Ending the Epidemic strategy? What are the 4 pillars of it? So folks understand. I mean, I won't belabor the point about West Virginia being left out again, because I'll just say it every time I see you, and I'll just say it every time I see you, right? So everybody on the call knows that Harold made a decision to leave out West Virginia. I'm going to just say it's all him. He's the one. That's the guy. Call him up, ask him why, tell him how come. Now, Harold, tell us all why it is that we need an ending the epidemic strategy, what it is and what the 4 pillars of it are, and why you made the personal decision to leave West Virginia out of the ending the epidemic strategy. Go ahead.
Okay, thank you all. Good afternoon. And in case you didn't know, Toni is joking. I did not make this personal decision to leave West Virginia out. The Ending the HIV Epidemic initiative was conceived and given birth to by several other people who made those decisions. And in making those decisions, what they wanted to do was focus phase 1 of the initiative on the 48 counties and 7 states that comprise 50% or more of the new HIV transmissions in the United States. So West Virginia is considered sort of phase 2, though the rest of the country, where we need to be monitoring and closely looking at those HIV epidemics and the fact it's impacting HIV transmission rates and responding appropriately. So I'll get back to that piece of that, Toni. But the initiative itself focuses on what we call 4 pillars. One is to diagnose people as soon as possible with regard to HIV. So really scaling up the availability of HIV testing in both traditional and non-traditional settings, working with CDC and others to implement CDC's guidance around HIV testing. But right now we're also considering how to revise that guidance as well, which calls for universal testing for individuals ages 13 to 64, and more often for those who have risk. But as you all know, there are issues with screening for risk. And so really working with CDC to look at that guidance and see, does it really and truly fit where we are today in the epidemic? The second pillar is the treatment pillar, treat people as soon as possible after diagnosis. So this calls for us to stand up rapid entry programs and working to sort of shrink that window between the time someone is diagnosed and when they enter care and treatment and start antiretroviral therapy. The health benefits for the individual, the benefits for sort of community health when it comes to U equals U, undetectable equaling untransmittable, reducing number of new infections. So that methodology of treatment as soon as possible, rapid and immediate, really and truly works as a second pillar. The third pillar is on scaling up HIV prevention so that we're using everything in the HIV prevention toolbox, which means condoms, behavior change, PrEP, PEP, syringe services programs, which we also know works. So that's our third pillar. And then the last pillar is the response pillar, how we use our surveillance data to respond to address clusters of HIV transmission and rapidly deploy the both needed HIV prevention, diagnosis, and treatment services that might be needed where there might be outbreaks that have been monitored using surveillance data of HIV. So those are the 4 pillars of EAG. It aligns with our national strategic plan and calls for a 90% reduction in new HIV infections by the year 2030. So, and HHS is funded, various entities in HHS. So we've talked a little bit about HRSA, CDC, NIH, and the Indian Health Service are all funded under the EHE initiative to be able to move in this direction. The president's budget request for FY22, which came out last week, includes a $670 million pot of funding for ending the HIV epidemic initiative. Well, so that's kind of how that fits.
All right. So how does ADAP fit in? How does ADAP fit into that? Because I'm going to lead into Alicia next. She doesn't know that, but since she's paying so much attention, because I can see her thinking, so she's ready for some questions and stuff. So I need you to tell us now how this relates to ADAP, and then we're going to pivot over to her. So she's going to get her presentation ready for the people on behalf of the people.
Okay. All right. So let me tee up in Alicia. So EHE currently, the $670 million, what we don't yet have is sort of the breakout per agency of how the president wants that to go. There is a pot of money that goes to HRSA, both the HIV/AIDS Bureau, which is responsible for the Ryan White program, and ADAP, and also HRSA's Bureau of Primary Health Care, which is in charge of the health centers program. And so the health centers have been charged with scaling up HIV testing and access to PrEP in health centers across the country in EHE jurisdictions. The money that is going to HRSA through the Ryan White program is going to Ryan White Part A, as well as the 7 states. And that money is not specifically set aside for the AIDS Drug Assistance Program. It is designed for programs to get those who've been lost to care, re-engage them, as well as ensuring that those who are in care and not virally suppressed can achieve viral suppression. So they have the ability to create new service categories or new ways of approaching and dealing with those barriers that get in the way of viral suppression, but not necessarily ADAP. I think in the long run, we have to think about the fact that if we are successful in finding and re-engaging those individuals, many of those individuals might end up on state ADAP programs.
So I mean, I'm coming to you. Get ready, Alicia, because here it comes. I'm throwing a speedball your way. Here's the reality, though. I mean, you know, in light of COVID, I mean, most of our local health departments, county health departments, and others have been focused on, been detailed or redetailed on the COVID. And so that's one piece of this. The other piece of this is that, you know, the number of people that have been unemployed or underemployed who now may need to access ADAP, who didn't have it before, you know, have the need, when I say that, have the need to access a drug assistance program before COVID because they lost their job or something. It seems like we're not coordinating this, right? It seems like we're not putting these two things together, and they're just hitting us in the back of the head like, ooh, COVID got you, but it got you in a different way, right? It got you in that now your state or your county is now got all these people who need additional assistance, where I feel like we hadn't thought about it or we didn't think about it. And I know Alicia was like, what's this got to do with me? And I'm like, but I mean, I think I want us to think about it as a part of how we're thinking about what we're going to do to fix it. Is that it's not just people, you know, at 200% below poverty. We've got a whole new group of people who are relying on this program and on other programs that I just don't think that we're thinking about and talking about. So, Ms. Jenkins, to you. Uh-oh, you're on mute or something. It says you're not, but we can't. Can anybody hear her? But I know I can't. Look, I had teed this all up. I had teed this all up for you so nice and good. I hate to give you a spotlight to somebody else because Tim Horn's chomping at the bit. I see him. He's chomping at the bit.
Alicia, is your computer microphone muted?
I'm unmuted. Can you hear me now?
Yes, we can.
We can.
Awesome. Thank you. Thank you. I'm actually on the phone and not using the computer.
All right.
Yes. Toni, thank you for teeing me up, and Penny, certainly jump in if I forget something. I think, you know, one of the things that, you know, for us in Missouri, as it relates to ending the HIV epidemic, is that, you know, while we've been in the midst of COVID, we still have made a good faith effort to continue to move forward with our EHE activities. It certainly has not been easy, but we have strived nonetheless. For example, some of the things that we've been doing is really working with our FQHCs. We started out having conversations with the Missouri Primary Care Association, which is the hub for FQHCs throughout the state. And we actually picked a couple FQHCs to start small to have some conversation about, you know, we are the Bureau of HIV, STD, and Hepatitis here in the state of Missouri, and here are some of the activities that we have going within the Bureau. And one of the things I would like to preface is that not only did we talk about EHE, but we also talked about what we're doing with hepatitis elimination, what we're doing with prevention, and how can we partner with you to help you promote PrEP? Because we're trying to get to the same people. And so we've been having that dialogue, and what we found is that, one, we think everybody knows about Ron White, not at the level that we want them to. And so we have to do some education there, and we are. The other thing, too, is how can we involve FQHCs and other partners? And because even though we have our EHE efforts are focused statewide, we really got those dollars because of our rural dynamic. And so we are really focusing on our rural efforts right now simply because that's where you have what I call windshield time, where people have to drive a lot to get to a provider. And you know, what are the access to telehealth and you know, all those kinds of things that we really need to take a look at from a systems perspective, and really thinking about it, not just, you know, just throwing stuff at it, but how do we, where are our gaps and how do we build system capacity? Mm-hmm. And so we've been doing that. And so we're hoping to, so our plan is to really work with our FQHCs to have a menu of things that we're working with. We're going to be preparing them to do STD, HIV, and hepatitis testing, working with them to do education and training as it relates to those areas. And again, and also talking about what do you do when you have a newly diagnosed HIV individual who comes into, you know, your facility and who is needing support services. And, you know, we've had some conversations with physicians and doctors and who say, you know, that's not I'm not an ID doctor, but I want to know what to do and how to do it so that people, one, can get served in their own communities if they so choose. But to also, if it's beyond my scope, how can I connect those individuals with an ID doctor somewhere else? So we're really, you know, having those conversations and cross-connecting people throughout the state, rural doctors with urban doctors, to have conversations about, hey, what are you doing? And how, you know, to really triage and to work together on some of these things. And so we're really excited about that. The other thing, too, that we have noticed as we have been kind of working through this is that our data is important for us as how we drive our work. It's very critical. I will tell you, COVID has impacted our Bureau of Disease and Reportable Informatics quite a bit because they are working on COVID things. But we've also been able to have conversations with our leadership about, you know, we've also have to have capacity to do both. Right. And so, and we are working in tandem to move some of those things forward because we have to be creative in how we, you know, to get them extra support so they can process, you know, records and reports that come in of, you know, various new cases, and that we can get those out, and the goal really getting people linked to care in a timely fashion so that they don't have to wait.
Well, now, I'm going to jump. You haven't been on these before. I jump in and it's rude and it feels rude and it is kind of, but I do it anyway because it's my webinar. So here's the thing. So let me ask you this. So what about people impacted by COVID in Missouri? Are you seeing higher numbers of unemployment? Are you seeing providers trying to provide services, or not trying, actually providing services to both people living with HIV and impacted by COVID? What's been the role of the HIV service providers in response to COVID? Because, you know, I mean, that's who's going to lead a person to ADAP and understanding, you know, how to access the treatment. But, you know, we also have this COVID going on out there and people needing support. So I'm trying to figure out, you know, kind of how have those two things merged or meshed or not?
And so one of the things that we did, you know, we are Ryan White Part B, but we also work collectively with all the other Ryan White parts throughout the state. And so we do have communications and conversations about, you know, what's the dynamic? I'm in Jefferson City, and so, but what's the dynamic at the local level? What is it that we're hearing? What do people need, and how are they getting served? I will say, I think as a state, we have a strong Ryan White HIV medical case management system. I think we have folks who really care about their clients. I think we, you know, the phone calls were made, you know, people, you know, safety measures were taken to get a hold of folks to figure out what it is that you need and how you need it, and making sure people who are newly diagnosed or who are lost to care or reconnected in care and back with their meds and all those kinds of things. I think, you know, those things are happening. You know, I think we've been fortunate in the sense that we haven't lost our capacity to serve our clients. You know, it looks a little bit different, but we have to do what we got to do to ensure safety and well-being of those that we're trying to serve. And so each region throughout the state is different. Obviously, we have our population densities in our metro areas, Kansas City and St. Louis. However, when you think about the rural footprint, you have to think about that's a lot different when it comes to making sure people's nutritional needs, access to dentists, providers, and, you know, fortunately, I think we have providers who are able to switch quickly to using telehealth as a way to be able to continue visits. Now, then you also have to think about the dynamic that you also have individuals, because of their care and concern for their own personal safety, how they decided whether or not they would venture out early on during the pandemic and what they would try to do. So we're continuously working through the process of what are people's needs, how are we doing, and what do we need to adjust as a system to make sure people's needs are met.
So, okay, thanks. So I'm going to call a couple other people. I'm going to pivot back to Tim and to Harold for a second, because a part of this conversation really is about what are some of the priorities that we need to be talking about here, but also what are some of the differences that we're seeing in urban versus rural environments when it comes to ADAP currently as it's being implemented or utilized, and what do we think is going to happen in the future? You know, because I think that's what I worry about the most is that this may impact all or some of the jurisdictions that either didn't expand Medicaid, or it will impact southern, rural, either if not the entire state, the counties that have a rural designation. So, you know, I guess I'm trying to figure out long haul, what do we need to be doing in helping? How do we need to help and support counties and health departments like Ms. Jenkins to make sure that people living with HIV, people impacted by COVID, people impacted by viral hepatitis, and substance use disorder are being able to access the critical services that they need in rural communities?
Yeah, no, I think that's a great question. And I just want to echo, you know, something, you know, Alicia's point around sort of like the need for that systems coordination. That is absolutely critical. And I think that the one thing that, you know, ending the HIV epidemics, and, you know, and I will just say that there are a number of the ending the HIV epidemics that we're seeing really do precede sort of like, you know, the federal ending the HIV epidemic. So there really has been like a lot of states that have been thinking about this for a long time, a lot of areas that have been thinking about this for a long time. So, and that really what that demands is it really does demand a great deal of coordination. And so that coordination, it has to be between the ADAPs and the Part Bs and the Part As. It has to be with the Part Cs. It has to be, to Alicia's point, like with the maybe even some of the non-Ryan White, like FQHCs, some of the disproportionate share hospitals that are providing care, some of the rural hospitals that are providing care. So that there really has to be that coordination to understand what in fact is missing, like what are the needs. And that is not a one-time thing. That is something that has to evolve over time. second component of that really is community engagement in terms of it's that need for community engagement, to really figure out, like, again, what is absolutely required to not only address this just in the rural areas, suburban areas, in the urban areas, but really just like what is required on a state level. And I think something to think about it, like from the ADAP standpoint, that even though I think under the EHE funding streams, I mean, there really are some very like finite objectives on that, but really, I think, from where we think about it, at least at NASTAD, is that, the ADAPs really, there are a number of different sort of priorities under the Ending the HIV epidemic, which is number one, is really just ensuring that, formularies are very much in alignment with the best HIV treatment practices, right? And that includes, establishing, that includes those that are established by the HHS, treatment guidelines. So that's really one priority. And second is like, striving towards, formularies that meet the comprehensive like pharmacological needs, of people living with HIV. And this includes mental health medications. It includes medications for chemical dependency. It also includes like, gender affirming hormone therapies. All of that, really is absolutely critical to ensure that individuals living with HIV have access to all of the different sort of interventions that are absolutely critical to achieving the HIV outcomes that we were looking for, including those that are synonymous with ending the HIV epidemic. Also, ensuring that they are securing medications at the best possible prices, and that that they are able to not only to ensure cost containment, but they're able to actually work that in such a way that some of those savings are actually being flown back into Part B and those Part B services. So that is absolutely critical. Also, and I think this really does dovetail with certainly with some of the rural health objectives, which is maximizing eligibility based on FPL requirements, amount of calculations that are actually used to assess income in the context of FPL, and then finally also streamlining eligibility, particularly in the context of the rapid start treatment paradigm, which really does require eligibility determinations that can be made in
okay, whoa. Okay, listen. There's slow kids on this call, mainly me, right? Rapid treatment paradigm. You went down a rabbit hole about FPLs, blah, 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 la, 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 dee, da, da, dee. And now all of a sudden, the next thing I know, you're gonna say you're cooking up the cure in your bathtub. Look, what is all of that stuff you just talked about? So you talked about an FPL impacting this. What is an FPL? Everybody don't know that.
Okay, all right. Thank you for that. I appreciate the you pumping the brakes on this. So our primary sort of determinant of ADAP eligibility is based on the federal poverty level in terms of like where you are in relation to the federal poverty level. So and that ranges in the United States from 200% up to around like 500% in some jurisdictions. So there's a lot of variability in that. So one of the, and I think that if there's an opportunity to increase that eligibility criteria, so maybe a jump from 200 to 300% or 300.
Well, but what does that mean? What does that mean in people language? That so does that mean because I don't have a job, I automatically qualify for this thing? Can I make some money and get some support? If I make money, but I still need help because these medicines are expensive, what do I do? You're talking crazy talk to me, sir. Crazy talk. FPLs, blah, blah, blah. Sir, help me understand. I just need my medication, sir.
And absolutely. And all of the above that you've referenced, that is, it's a site, just based on where you are, just on your financial eligibility in terms of the income that you are bringing in. Again, because these are payers of last resort, it's just that, that there is going to be a financial eligibility determination, very similar to the way Medicaid programs are set up. So, a similar model is applied to ADAPs. a similar model is applied to, the different Ryan White, parts. So, that is going to be absolutely essential. So in thinking about that, what are the income requirements, for to qualify for ADAP? What are the opportunities, for us to maximize those, and for ADAP programs to think about, how do they maximize those, so that, if we start to see folks who are like up around 300% of the federal poverty rate.
Okay, so I make $20,000 a year. Do I qualify?
Can somebody help me? I don't have my FPL chart up. Let me see.
I mean, because that's really
it's not
right?
high.
Oh, I was not prepared for this.
Right, because that's
We're
really
talking like
right?
$13,000.
I mean, this is really for you. This is for you, Harold, Michelle, because everybody jump in. Is that, part of this is that people, I think, unless you are going into a case manager's office who figures this stuff out for you, I mean, there's a place, there's a point in this in which we have to really kind of say, hey, there may be people who are not engaged in the system the way we want them to be or need them to be. So how does John, Johnny, Juan, or Juanita know that she or he qualifies for this program if they are in a rural community that may not have an HIV organization? Because here's the other piece of this, is that you keep talking about take a pill, take a pill, take a pill, and we've got medicine for that. So what about the behavioral health outcomes? Who's giving Johnny and Juanita the pep talk, not the prep talk, but the pep talk to get in there, get the medication, get screened, make sure they access medication, make sure they access treatment, and make sure that they are adherent to that treatment? I mean, so I feel like this conversation is kind of like 5 carts before the horse. And so I want to ask Harold about this. I'm going to come back to you, Tim, because see you chomping at the bit. But I'm going to go to Harold with this and talk to him about ADAP. Yes, that's our drug assistance program. But what about a behavioral health work that is the one that's going to be the part that gets folks to treatment and keeps them in the treatment? How does the Ending the Epidemic plan respond to that?
So a couple of ways. So the money that goes to HRSA for the Ryan White program can also be used for mental health services, behavioral health services as well. There's also SAMHSA at the table, and they have been coordinating, and they also receive a pot of funding, mostly the Minority HIV/AIDS Fund, which helps them sort of target HIV communities, particularly in the minority communities, which also include the rural communities too, for this work. They've recently put out a guide, and once you call on somebody else, I will look and get the link and put it in the chat, because it's a guide that talks about what are some of the best evidence-based models for providing mental health, substance use disorder services in HIV settings. So, so they are at the table, they are doing the work. The other piece that I would say is really important to this discussion, and also as we're talking about funding to support and meet the needs in rural communities, the American Recovery Plan has a lot of money in it that I think does a couple of things when it comes to states that didn't expand Medicaid. They're sort of what they've been calling sort of the sweeteners or enhancers to get certain states to relook at sort of those reimbursements and getting involved and expanding Medicaid. For example, Mississippi, I've heard recently, is looking at joining in now as a result of some of the sweeteners in the American Recovery Plan Act. The other piece about that act that I think is really important for rural communities, there's a lot of money for mental health, behavioral health, substance use disorder treatment located in there that's supposed to go to SAMHSA through the block grants. So in thinking about how states like West Virginia use its SAMHSA block grant, one of the things that I'm trying to educate the community on, as well as my federal partners, is this is a great opportunity because, like you talked about, Toni, there's there's an intersection of all of these issues, particularly in rural communities. So when they're thinking about how they're going to use these funds, I want to make sure that our communities are at the table and that our needs are also being met, because there's these new funding streams that are coming, some as a result of COVID, some as a result of the priorities of the new administration and thinking about infrastructure. And there was a comment about the decimation of rural hospitals and the lack of healthcare infrastructure in rural communities. Look at the funding that's coming through the American Recovery Plan Act, because some of that, as well as the new infrastructure bill that is being proposed, also talk about ways to strengthen public health infrastructure. It's just not roads and bridges. Which is really important.
Well, okay. So do we have Ali? Are you here, Ali? Because I thought I saw you earlier.
Yes, I'm here.
All right. So tell me what's going on with you. What are you thinking about ADAP?
That's a very open question. I mean, what do I think about ADAP?
Yep.
ADAP is a main pillar of what we do here in terms of what has been said already by Tim and others have said in terms of the purpose for ADAP. We say we will end the epidemics mostly because of ADAP, because people who are living with HIV, most of them are very poor people who do not have the wherewithal to have smooth access to HIV medications. You know, having the tools for ending the epidemics is one, including the medications. But if you can't have, if you can't afford it, you might as well not have the tools. So ADAP makes that a reality for most people here. I'm from West Africa. Right now, HIV in Sierra Leone, where I am, it's like it was here in the 80s. People are dying every day because they don't have access to these medications. So ADAP makes that difference for people here. In South Carolina, for the past several years, we, like other states, we're on the verge of going back to a wait list because our funds kept dwindling. But we kind of took a turn for the better this year, where the rebate funds have come up again. So for me, when the name is implied in the name, when it says AIDS drug assistance, it is indeed a very good assistance program that we use to leverage people's access to medications here in South Carolina. So that's what ADAP means for me.
Okay. I mean, because I think that one of the things I don't know about every place, so I'll talk a little bit about West Virginia. One of the things that we're seeing in West Virginia is that we're also seeing, an outbreak. We've got an outbreak in the state, but we also are trying to figure out Hep C elimination, Hep B eradication, Hep A implementation, screening. So it's, and everybody's doing this in the midst of COVID. So I'm trying to figure out for us and I think for everyone, what are the systems that we need to put in place and have in place to ensure that folks who need to access ADAP can? What are the systems and the things that we need to in place to ensure impacted by HIV and I say hepatitis C as well, have access to drug assistance programs, particularly those that may have be experiencing co-infection, because I guess I still just feel like we haven't really kind of come to terms with like the case in Texas where many of these individuals may or may not end up at a pharmacy to be told that they, or the way it was set up before the new funding came in, that they might have just gotten to a pharmacy to get their script refilled, and they would just get told no mas, you're out. We can't fill that for you. And then there's no kind of connectedness to, well, here's, you know, how we can get you medication through either a compassionate use program or whatever. So I mean, I guess I'm a little, I don't want to say tongue-tied, but kind of twisted up in the, how do I make sure that no person in this country who needs access to medication can't get it either through ADAP or through some sort of drug assistance program? And this is, and I think this is probably more directed for Tim and Harold. Tim, what he thinks needs to be done, and Harold, what actually can be done.
Before they answer, can I jump in real fast?
Yeah, absolutely.
I think there's a couple of things. One, I think that I hope that both HRSA and CDC with their EHE funding bring those phase 1 states together to have a conversation about what's working well and what isn't working, and what do we need to consider from a federal level down to the state level on how to address some of the common things that people may be experiencing who are trying to implement EHE. The other thing I would also like to say is that it's not a cookie cutter approach in the sense that while we have an overall statewide infrastructure when it comes to administer Ryan White and how all the grantees work together, EHE provides a different opportunity in the sense that all you have to be is HIV positive. Okay, so the goal would be to, if they are eligible for Ryan White and they want to participate in Ryan White, that we get them into Ryan White quickly with a warm handoff and get them set up to go, and that takes care of that. But you also may have situations where you have individuals who are not eligible for Ryan White because of their income. And so how do we make sure those people are connected with patient assistance program or support them through EHE funding that allows you to be innovative with your spending, but keeping in mind that everybody didn't get all the money that they wanted, and drugs can be expensive. Mm-hmm. And so when you think about, and we've been having conversations with other states too, which I think is very important, and like picking up the phone call, scheduling some webinars and saying, hey, what are you doing? This is our issue. And having that dialogue on how we can address the gaps that we see in order to make sure people are connected, they get their first appointment, they get on their meds, and we can start moving them towards viral load suppression.
Okay. So you think, so you think if you could maybe even talk with the other phase 1 jurisdictions on a more consistent basis or a more on the ground basis of what's working, what's not working, who, you know, and, you know, yeah. Is that what you're saying? I just want to make sure. I think the biggest thing for us, we have a lot of the pieces already in place. We're not going to duplicate what's already working well. I think the biggest thing for those people who are not in Ryan White and who are like coming through the EHE pipeline, so to speak, is having a strong process for getting them on their meds and paying for their meds really quickly so that people do not have to wait. Does that make sense what I'm saying? Yeah. So, but I think I'm also asking the question of, okay, so what if Johnny doesn't meet that federal poverty level and he or she needs to go to the companies directly, you know, or needs to figure out another way to get, people don't qualify. We act like, I think sometimes that everybody who signs up for Ryan White gets it, or everybody.
And they don't, but it is our responsibility. And one of the things that we're doing is kind of taking a hybrid approach as we brought on a couple of staff who are kind of like disease interventionist specialists, but also kind of have a service coordination component. And the goal is to use those staff for those people who have to connect them with a patient's assistance program, mapping those things out. So basically, if you're going to have situations where you're going to have people who are employed, they have insurance, great. You're going to have people who are eligible for Ryan White, great. You're going to have people who are going to be Medicaid eligible, and then that's where you're going to send them. Okay, that's great. But the people who have nothing and nowhere to go, we have to connect them with patient's assistance program and triage those cases to the point to where we get them connected and nobody goes without their treatment.
But do you think
and it's not
and I think that that's exactly the point I'm trying to make, is that this is not an easy task, right? It's not everybody walks in, take a number, and once you get up to the window, you got everything you need when you walk out, an hour later. That's not how this works. And I think that particularly when we're talking about people who are maybe coming in with some sort of lived experience around substance use disorder, et cetera, that's also not the most consistent client. So are we doing all of the things that we need to do to ensure that all of the people or the people that need access to drug treatment are able to access it? Tim, what are the systems that we need to change or put into place?
Yeah, well, I mean, short of like a national universal healthcare in which, there's sort of like equitable access, to a single point. Other than that, I just really want to underscore Alicia's point, which is just that it's that it's beyond the systems coordination, but that systems navigation is just imperative in HIV care, just because of the complexities involved. And you're right, it's just like, no one person's gonna be able to come up to that counter and just say, I need this and this and this. It's just like, unfortunately, our US healthcare system is just not built that way. So we really do, rely on our providers. We rely on our case managers, to really just their familiarity and their understanding with, not only in terms of the way the systems works, but in terms of the way things work on a jurisdictional level is absolutely critical. And the one thing I would just say, just like when you do take a look at even navigating an ADAP, it's just like when you've spoken with one ADAP, you've spoken with one ADAP. Like, ADAPs in all 50 states and the territories, they operate in very, very different ways. So even for us to come together and thinking about so how do we sort of, ensure that we are configuring ADAPs in such a way that they are being responsive to rural health needs, that they're being responsive, to the overarching goals of the Ending the HIV Epidemic initiative. How do we do that? It's very, very difficult to do in sort of like, one sort of set paper, just because of the different opportunities and challenges that exist in certain states. And I think sort of circling back to your point in terms of like, well, what do we do when there's like in the case of Texas, like how do we respond to that effectively? Well, in some states we have legislatures or executives that are a bit more sympathetic to the Ryan-White program than others. So what's the flexibility there? What do the relationships look like between the Part Bs and the Part As? I mean, is there a way that that the ADAPs can work more effectively with the Part As, particularly if there are any sort of like budget shortfalls? What are some of the other opportunities that exist to ensure that? And I hate to say it, but it just is given the way things are sort of set up. Is it's like it tends to be we need to be very sort of like eagle-eyed about this, like really on a state-by-state cases, and that can be very frustrating and really maddening from a planning and intentionality standpoint.
May I add to that?
You may.
I do agree that the way the U.S. healthcare system is set up is pivoted mostly towards sick care. If you look at the funding, for instance, in my area in South Carolina, from both the states and federal funds, 90% of the funds we get go to HIV care and treatment. And of the 10%, actually not 90%, about 95%, only 5% is left for HIV prevention, STDs, and hepatitis combined. This is a very big problem because it seems like the entire healthcare system, you get more access to care when you're sick. I know the insurance companies, they have actually private insurance companies. They encourage now people to be more wellness oriented, so that because they know that by the time you get sick, they spend a lot of money. It's into their bottom line. So I think that if there's any systems change, it should pivot towards that. Another thing, like Tim was saying, is this big gap between what the funded what the government supported programs are doing compared to what's happening in the private sector. One of the biggest things that keeps me awake at night is that when you look at the care continuum deliverables, the linkage to care, retention in care to viral suppression. When you look at the numbers for South Carolina, for instance, we're doing so well with the round-wide funded programs. So, but then when you look at the state average, it's that's like a 30% spread between that. So the numbers go way down when you look at the entire state. Well, if we're not going to end the epidemics if the most proven programs are only for those entities that are funded by the federal government. How do we translate what I call perpetual pilot studies to the rest of the population? How do we enter into the offices of private providers, FQHCs, health departments, where the majority of the indigent population go for their care? Most people who need care, who cannot afford it, whether even though the ADAP is there, some people don't even know about it. They go to their free clinic, they go to their FQHC, they go to the local health department, and we have to find a way to translate these programs which HRSA and the CDC have put together, which are proven to be very effective. We have to find a way to extrapolate those programs to the rest of the population. Unless we do that, and until we do that, we're not going to end this epidemic. Because we are only, I mean, we have in South Carolina, there are about maybe 22,000 people estimated to be living with HIV. The round-wide program reaches maybe half of that. So the rest of the population is out there, and the funds that are given to us are so restricted. You can only use it in certain ways. So by the time the year is over, every year we have to ask for carryover because we didn't use the money. Yet there are systems and places within our borders, especially rural areas, that go without care, without services. But the guidelines and the policies that within which you operate does not allow us to go beyond certain limits, even though we see the problems beyond those limits.
Thanks, Ali. I can't say that this is like a happy topic, right? But that makes me even more distressed because I think that you're kind of right on. Like when we look at who are the people that are either outside, because if you say it's half, do we know if half of those are, what percentage of those are privately insured or getting treatment and care through another mechanism, and how are all of these kind of groups working and playing together? So Harold, what are we going to do?
So I think there are a couple of things that for us to think about. One, and Tim talked about this a little bit, in that ADAPs are sort of this mix of federal funding, state funding, rebates in some states as well, that all sort of combine to sort of make that mix of the ADAP budget overall that allows us to serve individuals. I think one of the challenges that we have is that many of those budgets have been flat funded. Many of those budgets, we expect states to cut their ADAP budgets or their contribution to ADAP, because many of the states are being hit just as hard as sort of the local businesses and the economy, which then drives sort of that state revenue that ends up funding things like ADAP or roads or some of the other services that we get from states. So all of this is something that I think we have to watch, and we have to continue to work with legislatures, both at the state and the federal level, to make sure they understand the needs that we have. Because the challenge is, on the back end, if this is flat and we're doing this work on the front end to re-engage individuals in care, prevent new transmissions, find those who are positive not in care, and we begin to sort of, get them into the care system. Like Alicia is pointing out, some of those individuals qualify for Ryan White, some of them don't. And so what happens when we sort of tap out the Ryan White program and we haven't had increases over there to be able to absorb them in that service system or with state ADAPs? So I think so there's work to be done to both at the federal and the state level to make sure people understand this. And then also, like you've said, there's sort of the interplay between sort of the issues and the service needs. And that in some cases, there are services that are sort of slated for funding coming through the federal budget that aren't necessarily HIV specific, but we've got to pay attention to those. Food, housing, like the president's budget also includes $500 million for homelessness assistance grants, and it specifically mentions homeless youth. So it's not necessarily HIV, but that's a large population of folks that we serve. But if you're not sort of paying attention to some of the budget discussions and negotiations, you might have missed it because you might have been focused on the $670 million and missed that there's $500 million for homelessness assistance grants that is, and also the mention of homeless youth. Many are at-risk youth for HIV. So there's a lot going on and there's a lot of moving parts. And it goes back to what Ali is saying about our fragmented healthcare system, where none of this is coordinated. And that's why luckily in HIV, we have this model of case managers on the front lines who are responsible for coordinating care and support services.
Right. So we have a bit of a question statement from one of my favorite people on the planet, that she does a lot of the best work. They do some amazing work. So Cordelia, I think you have a question, and this question is for the group. If COVID has increased the use of ADAP services, why have we not directed CARES and rescue funding to ADAP directly? I think that might be for you, Harold.
I was thinking about that. And I know that CARES funding did go to HRSA. I don't know that there was a restriction on it going to ADAP. That's why I was kind of scrunching my face up, because I was trying to think about whether or not there was a restriction on some of that funding being used for ADAP, or was it just for services? And I'm not sure that there was. So I'm sort of looking at
Cordelia, did I ask your question appropriately?
Yes, you did. Thank you so much. I know that there was some CARES funding allocated for services, not directed to ADAP. And that's why I am mind blown that those funding, CARES and rescue funding, does not provide some kind of assistance for ADAP.
Go ahead, Harold.
So, having worked at HRSA and understanding the way HRSA thinks, so they mentioned this as, thanks for the link, Tim, by the way, it provides one-time funding to help current recipients prevent, prepare, and respond to coronavirus disease. The $90 million is designed to help recipients in large measure to support core medical and support services. So the way HRSA thinks is that since this is one-time funding, we don't want you to necessarily use it to put folks on antiretroviral medication, because when that funding runs out, then what are you going to do once you've started those individuals on therapy? This is also similar to their policy where they look really closely if you're going to use carryover money for ADAP. You've got to be able to ensure that once you start those individuals on antiretroviral therapy, that you could continue it. So they generally tend to frown away from using one-time money for ADAP. And that's, especially if you're going to use it for medications. If you're going to use it for coordination services, they would probably approve it, but not necessarily in purchases of medications and starting folks on the antiretroviral.
And also that funding that folks received, I know what we received was a small amount in our world, and we used it for PPE, and things like that, food nutritional support, things that people actually needed to sustain themselves during the pandemic. We also were able to support some technology enhancements because we still had some HIV medical case managers with desktops. And so we were able to, with that amount of funding, we were certainly able to do some things, but it was small in and of itself. Right. But again, I want to keep in mind what Tim said was that each ADAP program is unique in and of itself. And so for us, you have to keep in mind, we don't do too bad. And we, because of the pandemic, we did, obviously, some people really secured and locked down and didn't get out and do some things. So, we lost a few clients along the way, but hopefully are working towards picking them back up who may have been lost to care for whatever reason. Some people just refuse to get out or to, even have people virtual and do the phones and things like that. The other thing that I want to mention, too, is that for us, we have conversations with our Department of Mental Health, who does get SAMHSA funding. They are subject matter experts when it comes to behavioral health and substance use. And so we have conversations about what our needs are and how we can partner. The beauty of it for us is that actually our old bureau chief that used to be here is now over at the Department of Mental Health. And so we definitely have an even better direct connect, and even also having conversations with Department of Corrections about people who are transitioning out of corrections and what their needs are and how we can support them. So there's a lot of dynamic conversations going on throughout the state, not only across departments, across regions and across local public health agencies, CBOs and FQHCs, just to make sure that people understand where we are with EHE and how we're trying to move the state forward to end the epidemic.
Yeah. So I want to see if Penny Williams, if you have something you want to add, and then I have a couple of things.
I don't really have a whole lot more to add other than I would like to just restate that Missouri doesn't do too bad. We've got, as far as our ADAP clients go, we've been very successful into moving them into comprehensive health insurance. And most of those individuals have not expressed a need for expanded services outside of the ones that have already been mentioned. So I feel like Missouri's on a really, really strong path to ending the epidemic in our state. We have historically been a very collaborative state. I've been in various national meetings and have continually been surprised at the Ryan White Part A's and Part B's who do not communicate at all, and they don't know what each other is doing. And because we do have a group of grantees who meet periodically, we stay in contact, we stay in collaboration, and we are all mostly on the same page with our efforts. So I don't have a whole lot more to add other than what I just mentioned. Alicia's done a great job in explaining our Missouri program to you.
Well, I mean, I think you have done an amazing job of explaining to me, especially Ms. Jenkins taking my ribbing along the way. I mean, I often just feel like we deal with some serious and heady and life-threatening and life-ending and life-altering stuff. And if we can't occasionally laugh a little bit, even though that humor is sometimes a bit morose, that I don't know how we make it through and continue to do what we all get up and do every day, because I'm certainly grateful for all of you and what you do and the roles that you do it in, because I mean, you all make me smarter every day. And so I'm always very, very grateful for you. I've known many of you for several decades, and I think that you've added to saving the lives of many, many people, or at least making their lives a little bit better while they were here. So here's what I wanted. Yeah.
I'm sorry, I just wanted to add another thing that has been very helpful within our state is we do have a clinical advisory committee that is comprised of doctors, pharmacists. We've had client representation of individuals across the state who give great input to the Missouri ADAP program regarding formulary, most current treatment options, not only for HIV, but those comorbidities that individuals with HIV sometimes have. So I feel like that also, because we have that statewide representation, we get the perspective of the rural areas as well as the more urban areas. And that also goes a long way toward combating HIV.
Right. Thank you. Thank you very much. So I'm going to ask if there's any questions for the panelists, please put them in the chat and I will ask those. And I know Jen is going to have 17 questions, but we'll go with just one question, Jen. That's all you get is one. And so put it in the chat. But as we get to the end, I guess I want to ask the question, like, what do we do to ensure that people in rural America have access to life-saving, life-altering HIV treatment in the time of COVID, whether they're in an EHE jurisdiction or not? And I'm going to start with Ms. Jenkins. She knew it was getting ready to happen.
So one of the things I'm thinking, I know we haven't talked about this, but technology is such a big part of our work. And I think that is certainly going to be a need as we continue to have those conversations. When you think about infrastructure building, the need for broadband in rural areas is going to be essential in how we engage with people as it relates to case management, as it relates to their healthcare provider. And so one of the things I know I do is we have conversations with our leadership about, what's going on with broadband, with our Department of Economic Development, how are those things moving? Because that's going to be key. The other thing, too, is we have to go to those rural areas and see for ourselves. We have to get out from behind our desk. We need to go out and talk to people. We don't need to push things down. We need to have an opportunity for people to engage with us and to send stuff up and to let them show us what their needs are and how we can partner, not just us do it, but to do it in collaboration with other agencies at the local level as well as throughout the state to ensure that individuals' needs are being met.
Okay, so thank you very much. I appreciate that. I am the Pied Piper of broadband as well. I think we've got to get the map done of where the broadband deserts are in this country, because I think people don't respond to it because they don't know that there's a broadband desert there. But I tell you, if I leave my house in West Virginia, I can't use my phone for another 40 minutes in either direction because I can't access broadband. But you want people to use and engage in telehealth. You want this, and you say this is the panacea. But I don't have I know so many people in rural communities that don't have a cell phone or share a cell phone. And that's unheard of to many of my urban dweller friends. What do you mean? No, there's a whole family on one cell phone. That's what I'm saying to you. And so I think that we do have to think about how it is that what we think of, cell phones and cell phone technologies are now just like a standard utility bill. They're like water, lights, and electric.
Yes, they are.
You cannot function in this country without one. So there you have it. All right. So I'm gonna take again, moderators live. Jen, I'm gonna give you 3 minutes in 20 seconds. And I don't know, I just picked a random number. That's all you got, Jen. Go. What is your big question?
I had so many feelings. Oh my gosh. Thank you so much, Toni. You know, at the end of the day, we've got to clear out room for ADAPs in these additional infrastructure funding bills. If that money is not specifically carved out, ADAPs will absolutely be left behind. And the issue with that is that even with every little bit of money that we can put into EHE, we keep thinking about testing as an intervention, and it's not. The biggest intervention that we fail to do is keep people engaged in care or to re-engage in care. And the biggest gap that we see is in rural communities. And that's because of the hospital closures. So, you know, I want to see commentary on that. I want to see how we're closing those gaps. And I want to see how we integrate not just this issue of telehealth and broadband and hospital closures, but how are we changing these policies in reapplication for ADAPs and Ryan Whites? You're going to be positive for the rest of your life. Why are we reapplying every 6 months? That's nonsense, especially for rural communities. So how are we filling these gaps that we know exist, and how are we doing that in a meaningful way by applying standards of care, by pushing the boundaries of what's possible as a standard issue in meeting the needs of people living with HIV, people living with HCV and substance use disorder? See, less than 3 minutes.
There you go. You know me and you love me because you did it the right way. You didn't get the hook from Toni Young. So, hey, Harold, what's that? What are you drinking? You knew I was going to catch you. Did you think you would take your sip while I was talking? Yeah, come on. What's in the cup? It's
Pepsi.
Sure.
Pepsi. Okay. I thought I had actually hit the stop video so that Toni wouldn't catch me.
But you know this isn't how that usually works. So, yeah. Harold, I think that Jen brought up a couple of things, like particularly policy related issues. Like, can you from en masse on top of the mountain called EHE send down an edict that says, you know, people don't need to reapply every 6 months, particularly in the light of COVID, but that maybe people can apply it can be annualized or, you know, or done when they, you know, show up, you know, every 18 months. Because that's one of the crazy things that was happening in Texas also. You know, people would go to show up and then boop, you know, guess what? That program's not available to you anymore. I think at least, and then people would know that they had a 1-year commitment of their medication rather than worrying about this every 6 months. And there's early, early childhood events for trauma. I can't imagine the trauma of that. Every 6 months, you don't know if you're going to have your medication or not.
So I know that HRSA, this is one thing that HRSA's HIV/AIDS Bureau is looking into. Especially with their role with Ryan White. They did relax some of those policies and restrictions during the COVID-19 pandemic. I don't know where they're landing in sort of coming out with revised guidance around it or not. Alicia might have Alicia or Penny may have more insight into where HRSA is with that piece of it.
Yeah, I hadn't heard anything new far as anything being relaxed additionally, but I definitely, you know, the points that were made today by Jen, I certainly was glad to hear them. I certainly will keep them in my mind as I move forward with having conversations with our project officer, as well as with other states. You know, what is it? Because I think what we have to realize with EHE is that there are some things that are going to come out that we may not have thought about before, just because of what we're trying to do. And so it's like, okay, we're seeing these things. Is it consistent through the rest of the phase 1 states? And if so, then how do we address it systemically so that we all kind of have a blueprint, so to speak, to work from, so that there's consistency, particularly if you're going to bring on other states in this process. I mean, we've got to use this as an opportunity to work out some of those kinks and answer some of those questions about using EHE funding and how that fits in with ADAP, so that people don't have to ask those questions when the new states and territories are brought in.
Right. So Tim, how do we get everybody everything that they need? I know we're going to dismantle it and we're going to have one payer and it's going to be the United States. Okay, so that's not going to happen. We're not going to get the insurance that we all want. So now what? You're on mute. You're on mute. So whatever name you called me, I didn't hear it.
So can you be more specific and just in terms of, yeah.
No, I can't because I don't know that it's more specific than that. Now that, look, do we have the system that we have, but what is the system that we need? Because we're not going to get a single payer program. I don't think we're going to see that. So now what do we do? Because we got people in Ms. Jenkins' territory. We got, people in West Virginia who, Medicaid has been expanded, but you've got other jurisdictions where Medicaid hasn't been expanded, and we got them. And guess what? We're still in the middle of a pandemic. And personally, I think we're going to have a fourth wave. What are we going to do?
Yeah, no, I think from an ADAP perspective, I think it's just, well, it's a couple of things. I think there just needs to be very careful inventory in terms of, how the programs need to evolve in this context. And I think I just want to circle back to sort of what happened in COVID. And I think that, just the, I'm not usually sort of a, like a silver linings kind of guy, but I think what was really interesting about COVID was watching how nimble so many of our programs actually were and how quickly they were able to actually adapt to that. And that, including things like, doing away with like in-person like certification processes, doing away with, the need to for physical presence, like on a signature, they can do a virtual signature, really just doing, and really sort of establishing a lot of these sort of mechanisms to really support physical distancing requirements in COVID, including like 90-day fills, and of course, like in Texas, that ended up being one of the factors that led to the budget shortfall. But like in many states, there really has been a lot of adaptability around that. And so, first, I think it's like taking a look at sort of like really how does the program need to evolve, and then sort of taking two different strategies. It's like, are there different ways in which the program can be evolved with like existing regulations, or the big question becomes is like, do we in fact need to take a look at a reauthorization of Ryan White to do that? Like, I'm not prepared to sort of comment on the do you or don't you move forward with that process, but I think it does raise fundamental questions for our great policy heads and our great community heads, and thinking about is that going to be essential there? And again, yeah, it's really about like, I think it's just realizing that, ADAPs and, Ryan White, service delivery is not static. I mean, it does require adaptability. It's going to required adaptability in sort of in the face of COVID. It will require adaptability in any jurisdictions that are in the HIV epidemic jurisdiction. So that is going to be absolutely critical. And I think that's, sort of the immediate, sort of a thing that needs to be considered in that way, to sort of getting us closer to where we want.
So that's a win in this, right? So when we're looking for a win, when we're looking for a silver lining here, is that these systems were in fact malleable in some ways, not as many as we had hoped or would always need, but in some ways. Is that what I'm understanding you to say?
Correct. Yes. And I think it's like thing about how we make ADAP work. And it's just like not to be, so now I'm gonna sort of revert back to like where my cynical sort of, first thinking comes in. And I just like, we are still, ADAPs are still operating an ever-changing landscape. And I think that this is absolutely critical. And I think about what's happening on the other provider level, and at the risk of getting my hand snapped by you, Toni, because I think that we're sort of like jumping the gun here. But I think it's just, for I think folks who are familiar with, the 340B drug pricing program in the United States, and the impact of the way 340B impacts our HIV care service delivery, our HIV prevention service delivery. There are some fundamental changes that are happening with that program, some due to, I think, policy threats, some due to the fact that just some drugs are they're going off brand and into generics, in some cases due to the way in which some of our patient assistance programs are structured. There's a big change that's happening in there, and because 340B is such a critical source of funding, ADAPs, that there is a potential impact on ADAPs for that, right? And I think that if 340B and the savings generated on that, I'm very happy to speak to that. I just don't want to hijack that conversation, is that the ADAPs might become even more responsible for a lot of the HIV care and treatment needs in the United States. So I think I think we need to make big improvements in terms to get where we want to be, but these programs also have to be really supplemented to the best of their ability, just so that they can remain nimble and flexible in an ever-changing landscape, particularly that's associated with HIV care in the United States of America.
Right. I'm not chop your head off. Here's my thinking is, and I've always believed two things about 340B. I believe that substance use and hepatitis C providers underutilize 340B to their disadvantage. I think that MAT providers didn't know that they could use 340B in the way it can be used. And so I think that we have probably missed the huge opportunity there, because I think those MAT, and when I say MAT, I'm talking about medically assisted treatment providers. And I think that one of the other pieces of it is that I think that 340B is often, or rarely, is rarely, I think, fully utilized by many organizations of color successfully. And clarity in who has benefited from 340B and who has not. So I think I want to say that. But I think that we should have a different conversation about 340B on its own merit, because I think that one for sure is a day-long conversation. Penny, what are you saying we could do successfully to get out of this?
To get out
of anything. How can we support people living with HIV better with the Ryan White program? How do we do it? What do we need to do? What do we need to put in place?
I think Missouri has a good start on it. I'm going to pat us on the back a little bit. Alicia had mentioned that we are in process of establishing some DIS, or disease intervention specialists. I'm trying not to speak in acronyms, but it just flows that way. So linking people to care, educating people in the community about what services are available. We do have in our rural areas several aid service organizations who are well known in the areas. Establishing connections with those entities to also further our education toward individuals in the community. Establishing those patient assistance program guidelines for individuals so that they sort of have a flow and know how to access those if they would in fact not qualify for services in our state. I really think that the collaborative communication has to continue across the board, not only with our Ryan White partners, but also with the FQHCs. We're working toward that in Missouri. Also, I believe collaboration amongst states is just really imperative, especially those states who are in this phase 1 of the EHE initiative. And then just sharing of ideas, hearing people at their level to know what the true needs are.
Perfect. And last but not least, Mr. Ali, tell us what do we need to be thinking about with regard to Ryan White and ADAP?
Let me defy that question to my very able ADAP program manager, Roshan McDaniel. Roshan?
Can you hear me?
Yes.
Yes.
Hi. So this is Roshan McDaniel. I'm the ADAP program manager here in South Carolina, and I kind of piggyback on what Penny said. Here in South Carolina, we have a great system of care and treatment between our Ryan White all parts and our ADAP. So we have been able to successfully coordinate with our providers to ensure, especially during COVID, we were very successful in ensuring that no one lost access to medications. We had a lot of, it's a great team. We worked around the clock at the very beginning to make sure that folks, whatever we had to do to make sure they got the medications, the communications that had to go out, and the coordination. So we were very successful in ensuring that our enrollees were able to keep access to that. The other part of that coordination is, I think, when you were talking about the 340B and the supplemental funding that provides for ADAPs and Ryan White Part B, some of that, because we've been successful in recent years. At one time, as Ali mentioned before, we were on the brink of what could have been a wait list just because of the budget shortfalls, but we were able to collaborate and turn that around. And just last year, so we have several support services, a wonderful outreach program. We're able to help supplement data to care services, which, particularly being in the rural state that reach, folks that may not have access to Ryan White providers. We have a peer advocate who works with those folks primarily who don't have a case manager and can assist them in getting services without that, and then also advocates to get into care services. So, I using the resources that we have and expanding those services. As an ADAP, we've just been very fortunate to have that great collaboration. We are a smaller state. We all know each other, and we can pick up the phone and talk to each other and say, here's a barrier. How can we work together to eradicate that? So I'm not sure if I answered your question or.
I really appreciate it. So I think that's exactly it. I think that you mentioned a whole bunch of things that I think are kind of critical that we often miss, which are particularly the relationship of peers working with people to help access and maintain services and maintain programs. But also, it made me really think about maybe we should do a call at some point soon about the role and impact of the downgrading of community planning in Ryan White and HIV, Ryan White on the care side, but also certainly on the prevention side. And what is the role of community planning in 2021? But I know that Harold really, 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 really wanted me to ask him, because he felt slighted, that he really, really, really wanted me to ask him what I thought he could do, and that the big system called them could do. You know how you always say they said, and usually it's them at HHS that they said. And so, Harold, help me understand how you're going to help us get out of all of this whole thing.
So thank you for that, Toni. I did feel slighted because she asked everybody else, what can we do to get out of this? And then she skipped me. But one of the things that definitely I'm taking out of this meeting is Alicia Jenkins asked for a meeting of the 7 rural states for EHE to come together and talk about what's working, what's not working. And I think also to share some ideas between what they're doing. So I'm going to make that happen because I think that's a reasonable ask. It has not happened from CDC or HRSA, so I'm going to take it on for the Office of the Assistant Secretary to have that convening and make sure that happens. The other thing, Tim talked about the fact that during COVID, there's been a lot of innovation and things have moved forward and things moved quickly. You know, we know, and we talked about on this call, that even telehealth is not the end all be all for everywhere. But I saw providers start telehealth programs in 4 hours. So nobody could ever, so not to be Pollyanna, but I will never believe, no, we can't do it from anybody's mouth at the state, local, community level. No, we can't do it. Just can't. I saw some incredible stuff happen out of a need for whatever your motivation was, whether it be to continue to be able to bill or to serve the community that you really and truly cared about. People made stuff happen. Even to the point where the HRSA Awards went out in March, right as we were beginning to shut everything down. From March through August, of all the health centers that were funded, 93% hired 389 new staff. We're talking about March through August. And I know where I was March through August. So that's what was happening. They tested 573,000 people for HIV. 2,260 tested positive and were linked to care within 30 days. And nearly 50,000 new individuals were prescribed PrEP at health centers through EHE, March through August of last year. So when we start thinking about what we can do and what cannot be done, it seems that there is nothing we can't do if we don't have the will. Now, the other piece that I think this proves is that if Congress gives us funding, we will use it in the appropriate ways. So this is money that went out the door in March to health centers. This is what they were able to do with it. This documented March through August in the middle of a pandemic, in the middle of staff being deployed elsewhere, CARES money having to be dealt with, all the rest of that. So the HIV community and the provider network and our public health departments are incredible when it comes to doing this. So that goes to your other point of, so what is needed? So we've talked about sort of how fragile the funding is right now with state budget cuts on the horizon, if ADAP gets flat funded, if 340B makes changes, then our ability to have the funds at our disposal to use become in jeopardy. So we've really got to work to ensure that those funding streams continue so that we can continue to use them effectively. The other pieces that we need to watch are, because we talked about several things, sort of rural hospitals, rural providers. We talked about the lack of broadband. Some of that is also wrapped up in this new infrastructure bill. Again, like I said, it's not just roads and bridges. There's stuff in there about expanding broadband access to rural communities. So pay attention to how that is all evolving, because that has an impact on this work as well. Also, healthcare workers, public health infrastructure, data, electronic medical records, all of that is sort of built in there too. It also benefits our HIV community. So there are things that are sort of working their way out of Washington that I think the rural community needs to pay some particular attention to, because there's some real things in there that really could address some of these things that that we've been talking about today. And then as we've talked about sort of states with waiting lists and the other things that have happened, back in 2009, when we had a number of states that had waiting lists, we had additional funding, supplemental funding for ADAP. But the thing that got us really out of those waiting lists was expanded healthcare access for individuals. So those states that began to expand Medicaid and provide health insurance rather than direct funding of ADAP, that too is also really important to think about, because that gives access to an individual, not just medical care, but not just drugs, but also medical care, mental behavioral health coverage that is also under there. So paying attention to states that might be expanding access to healthcare through some of these initial bills that have been put forward, like the American Recovery Act, also could be a way to help the HIV community. So that's all I got, Toni.
Well, and that was a lot. And that was a lot. And it was timely. It was informative. It was on topic. And now you can have a sip of whatever's really in that cup.
Thank you. Me and my Pepsi, thank you.
Okay.
So talking about EHE state meeting, there was a meeting, one meeting that HRSA organized in DC just before the pandemic, right? I know I was at a meeting. Is there are you speaking about the follow-up to that meeting or something quite new, maybe under the auspices of Toni's organization?
Well, I think that what Harold's talking about, Ali, is that he's going to bring together the 7 states for probably a call of what has been working and what needs to be working, because, you know, Ms. Jenkins has these brilliant ideas and she's now articulated it directly to Harold. It's now been on a recorded call. And like, if the meeting doesn't happen, I'll be like, hey, Harold, what happened to Ms. Jenkins' meeting? Ms. Jenkins called me and said her meeting never happened, that you were just trying to flex on the webinar. And now she don't have no call. And I'll be like, uh-oh, let me call Harold. Harold, where they call it? So to avoid all of that, Ali, Harold just said, hey, look, I'm going to do the call. Don't call me and bother me about it. I just said I was getting ready to do it. I think that's kind of what he said.
All right. I've already teed up the email to go to her to set up a time to talk about sort of what some of the issues are and how we might put an agenda together and bring some of the players in and see if this is just HRSA CDC or would she like HRSA CDC, SAMHSA, NIH at the table, IHS, all of them. So, you know, the Office of the Assistant Secretary heard.
Oh, listen, he used his official title. That means it's really going to happen now.
That was the day.
He said the office.
So maybe that'll be our first in-person meeting.
Yeah. Oh, well, I don't know about in person. It has to be virtual, but he just said the Office of the Assistant Secretary heard you. And that means the Office of the Assistant Secretary heard you.
No, it will probably be virtual since I want to do this sooner rather than later, because we don't have permission to yet fly people in.
I know.
And host meetings yet, but
Perfect.
I think we're getting there someday soon.
Perfect. I appreciate it, Harold. I think that would be a good thing, you know. And if West Virginia had ever gotten any money out of the Ending the Epidemic plan, we would have probably be able to attend that meeting, but since we didn't, I guess we won't. Somebody can send me some notes and maybe a cookie or something to tell me how the meeting went. But now I'm not a hater and I'm not bringing up the same old beating a dead horse thing, because that would be inappropriate. As one of our last and final things, hey, David, I think David Evans, our managing director of the Rural Health Service Provider Network, has some things to say.
Yeah, thank you all for the very informative call into our speakers. And I won't belabor echoing so much that I agreed with. But we have a survey in the field, a needs assessment for around rural health. We've been really successful. We've gotten almost 1,200 responses. But our survey sample is a little homogenous and it doesn't include as many service providers, whether they be anywhere from a peer advocate all the way up to, or maybe I should say, on par with degreed medical providers. But it just really quick trends that we're seeing is mental health and substance use has been seen and cited as the most needed service in rural areas, followed by, and this is to today's call, access to affordable medication. And I think particularly that speaks not only to HIV medication, but like Tim was talking about, access to a variety of medications that are of great interest and need by people with HIV. And just the last point with broadband is that in those who've answered the survey around their internet access, 32% access it through their cell phones, not through broadband, not through fiber networks. So that's something else that we all need to be looking at. So I am putting a, it's in the chat box already. And what I'd love is not only for you all to fill it out if you haven't already, but if you would be willing to contact me to see if we could work with you to really blast it out to your constituents, your colleagues, and your networks, because we really would love to get additional responses from a wider group of people. So thank you so much.
Well, thank you,
And
David.
so when you get the information, David, so tell me, how will that be used? How are you going to use it when you get it all?
I don't want to speak for Toni, but I do want to say that we are a community player. We are open access, and I know that we will be disseminating the results in some form going forward, because we want to benefit everyone working in this space, not just ourselves. So please look ahead for that.
Okay. So to answer part of your question is that, we wanted to do two things. One is that we wanted to be able to pull and show some of the data outputs as a result of post-COVID and what was going on. Because for some reason, some people just don't believe the crisis in rural America that really is there. And particularly around things like broadband and access to overall healthcare services beyond HIV. But, with substance use disorder, I think we're seeing it in West Virginia, we're seeing it in North Carolina with the rollbacks on syringe access programs, but we're also seeing greater need for mental health, as David articulated, mental health and other behavioral health services, which is a bit of my point earlier. And we wanted to see if it was just what's happening in West Virginia, is it happening in rural communities across the country? And we think that rural and rural adjacent communities are seeing a different level of impact than our urban partners. So we just wanted to be able to document it. If you can't prove it with data, nobody believes you telling them that people in rural America are in crisis.
Absolutely.
All right. Let's see. I think Tim answered Cordelia's question about, Cordelia had one. Listen, I'm trying to get back to the beach. I don't know if y'all noticed this, but I am literally on vacation. And I love you all, but I am literally trying to get back to the beach. And
so what this means is that everyone should ask as many questions as possible right now.
So I'm going to go with Cordelia's question last. And that is, I have another concern. How will HIV services be made whole for the diversion of the manpower that was directed to COVID, epi, and contact tracing? My opinion is, I don't think it ever is made whole. I think people go back to their workstations and realize what's piled up. And I actually contribute part of that to what happened in Texas. I think it wasn't mean, it wasn't ill-intentioned. I think people were off doing other duties and came back and focused and saw what the deficit had been, because they just said, we've got to keep people on treatment and make sure that people have access to treatment. And they looked up and they had run up a pretty hefty tab called $52 million.
But can I add to that really, really quick? One of the things I think is important is, as your agencies or your departments start to hot wash and do after action reports as it relates to COVID's impact, is to also be at the table and have some conversations about, we have to be able to do both. We have to be able to do contact tracing for HIV, gonorrhea, syphilis, and all the other things, just like we have to do contact tracing for COVID-19. What do we need to put in place so we can serve at the same time?
Right. And maybe that's one of the things that we can do, is that we can ask some of these jurisdictions, particularly in rural states and red states and others, but maybe all of, what's your after action report plan? Because I think that they maybe, I don't know if they're thinking about it. So, all right, I got nothing else. You've got nothing else. I've got something to go do. I want to thank you, Harold. As always, you never disappoint. You're always there for the community. Harold, seriously, thank you for the work that you're doing on Ending the Epidemic and with your team. Thanks, Marissa, for always getting him here on time and for sending that and for sending those emails out. I want to certainly acknowledge you. Tim, thank you so much. It's been a long time. And thanks. I hope we'll be doing more of this with you and alongside you. Ms. Jenkins, it's a pleasure to meet you. Ms. Williams, pleasure to meet you. Mr. Ali, pleasure to meet you. And to everyone, having an amazing day. Have a great week. And let's keep fighting the good fight.
Thank you. Thank you so much.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you. Bye-bye.